Hello everybody. First I want to introduce myself. My name is Nancy Fields. I'm a registered nurse. I work up in intensive care. I've been there quite a few years. I'm here to do a short little video, work with an intubated patient. This is going to be kind of a down and dirty, hit the high spots, but there's a potential that nurses out there may be helping with an intubated patient, working with him. I'm not sure exactly what capacity, but we're going to learn a little bit here. So first, an ET tube is an endotracheal tube. I might use some abbreviations. If I don't, maybe one of my students in the audience can holler at me. But here is what we call an ET tube. Now that's a pretty big one. If I take away this apparatus here that's holding it in, when you first put that ET tube in, here it is coming out of their mouth. So here is one going down, their trachea. What helps hold it in is a balloon or a cuff on the end. It's kind of like a Foley catheter balloon. It's filled with air. This is a pretty big one. It might take about 20-30 cc's here. I want you to see how it's flattened. So you add air, it puffs up. This is a pilot balloon, this dangly thing. You press that, it kind of gives, and that mimics this cuff. If this was totally flat, our little pilot balloon apparatus here, then that must mean that cuff is flat. So the cuff would be deflated. So if this is going down your trachea, down your windpipe, and this cuff is blown up, it's against the trachea walls. The idea is spit and snot that would come trickling down the back of your throat kind of sits there and does not go down around the cuff. That can set you up for pneumonia. We can only do our best trying to clean that out. That's when you get into oral care and why we do oral care every 2 hours. So that cuff stays inflated. So I wanted you to see how it looks deflated, that when it goes in, it's deflated. The respiratory therapist will blow that cuff up and then it stays tucked inside that tracheal wall, tracheal tube. I don't know if you could zero in. This size of this ET tube is a 10. Right there's a number, there's a 10. This is huge. I didn't even know they made them this big. These numbers, 31, 29, 27, when it goes down in the patient, so I'll switch to this one. When it goes down in the patient, it goes so far, and then there's these numbers, and when we chart, keep a record of it, we document that it would be like 18 at the lip line. Some places chart 18 or whatever on the teeth. This size tube is a 7. You can see that 7, here's a 7. So these numbers correspond to where it's, you want to keep track of where it's taped, where it's secured. When we give report, shift to shift, we would tell each other. It's a size 7, taped at 18 at the lip line. The thing holding it in is a commercial tube holder, it's called. So here we got our tube in. It's at 18 at the lip line. That looks like that pilot balloon's a little flat. I'm going to put some air in it, just so we can see the difference. Now, you might say, well, how much air goes in that? Well, to be quite honest, I don't know. I let respiratory deal with that, but if I can tell that is awfully flat, I might put in 2 cc's, 1 or 2 cc's, to tide us over until respiratory can come and I'll say, hey, I think that cuff was a little flat. In fact, many a time if the cuff is down, it's what you call an air leak. And I compare that to when you put an NG tube in somebody, or OG, whichever way. And you know when you check placement and you might hear air come up out of their mouth? You hear air. Well, an air leak, you hear air, because there would be air coming past this deflated cuff. It's an air leak. How do you fix the air leak? You blow up the cuff a little. But you wouldn't want to come along and just shove in 10 cc's and then end up breaking the little cuff. All right, there's that. So we got our cuff there. Now this commercial tube holder is exactly what it's called. That's how we chart it. I keep doing this because there's a computer back there and I feel like I'm documenting. This commercial tube holder comes in a box. It's Velcro. You probably takes a couple people to get it just right. This has sticky stuff on it you remove. And so here comes the ET tube. This is worn out from days of messing with it. You pull that little tape thing around, get that in there. I don't even do this. We don't do this. Respiratory does this. And I'm clicking that in. So now that that's how it's secured in. The old days we used to get tons of silk tape or whatever and do all that. Now we've got the handy dandy commercial tube holder. See these what I call little butterfly wings? Those move back, that moves back and forth, and it takes your ET tube right with it. That's, you do that once a shift because they'll get a little sore or something. It's pressure, so you should move it. We would typically chart right side, center, left, and nursing does that once a shift. You allowed to put this thing on pause? Whoops. Okay, we're going to continue on. I want to add something about placement of the ET tube. Once respiratory or whomever has intubated, they put that carbon dioxide, the detector thing on it, and it turns purple. Okay, and so there's also a chest x-ray done to double check placement. So when we talked about the number, it could be that has to be pulled out or even pushed back in a little farther. And then once the chest x-ray is done and we're all happy with where the ET tube is, then you'll document that and you want to keep it there. If we do that, I think I said that we document that, we report that shift to shift when we do bedside report, and if that's moved, somebody needs to know. Okay, let's do oral care. Oral care you have to do every 2 hours. The goal with an intubated patient is preventing VAP, ventilator associated pneumonia. Ventilator associated pneumonia. So things to do is head of the bed up. We try not to keep these folks flat. They're up, head of the bed is up 30 to 45 degrees, and the fancy beds tell you where it's at. Doing oral care every 2 hours. I told you about trying to clean as far down as you can and you want to keep that clean for spit and snot stuff going back down the tube. These little handy dandy suction toothlets, I'm just going to take that apart. You inline suction folks, but you also use this for oral care. We'll do the suctioning too. You poke your finger, close that's how you do oral care. These come in a huge package from in the supply room. You grab a package and it's always hanging around your vent somewhere. You take these little fellers out and use them. See this little foil pack? You can squish that. That busts it, and there's mouthwash. And that sponge is wet. So that's what you use, but I'm not gonna stick a wet sponge in the mannequin. I think I've already ruined her with this. So here I am doing oral care. You get down there, you're tell them, Mr. Smith, I'm gonna clean your mouth out like you're at the dentist. You can move the ET tube, get down, I get behind their molar, maybe to get clear back there, or around here, many times they have a nice handy tooth missing. You can get your little stick right down in there, do good oral care. I always say this, painting their lips is not oral care. Suck that spit out. Do that every couple hours, if not more. Vents are not nice and neat. They're drooly. They're yucky. They're wet. They're snotted up. They're spitted up. No, they're not nice and neat. You turn your patient, if you forgot to do oral care and you've turned your patient, all this drool is going to come running out. They're not fun that way. Let's suction a patient. If you're going to stick a tube down my windpipe and suck out snot and oxygen. Give me a little boost with oxygen. I'm going to show you that. But for right now, let's just do the suctioning part. There's a little tube moving in and out of here. It starts right there. Might be hard to see, but that moves in and out. You poke. You're going to poke it down there. Let go there. Pinch and then pull back. You got to pull that plastic back. So I'm pinching and pulling back the plastic. I say get it up to the hub. Here's a button thing you squish and pull out secretions. You might have to do that 3 or 4 times. Again, I will have given them a boost of oxygen. When you do this, they might cough, they might gag, the vent might be alarming. If the patient is really sedated, they might not cough and gag at all. You suction when their lungs sound awful. Maybe every time you come in to do an assessment, but if they're crystal clear, there's no reason to suction them. But that's what you do with suctioning. Sometimes that little tube gets caught up on the wall, that tube in there, and if so, just turn this. It'll get gone. Maybe you've had trachs before, so it's just like suctioning down a trach, only it's a longer tube. So that is inline suctioning. See this green thing? It's some kind of a filter. I forget what it's called. Okay, let's finish this a little. See this suction tubing? We set this stuff up. Here goes the connecting tubing. It's going over there to that canister. That's our secretions you suck out. So that's a bucket. That's a secretions, the collection canister thing. And that's hooked up to a regulator. That's where all that's going. So remember, we can do the inline suctioning. Take this off, open one of our little green spongy things, and do the oral care. I'm going to put this back on here.
How high should they have the suction set at on that canister?
Right now it's cranked to the highest.
Okay.
Let's go to the vent. Now this is all kind of a fake situation, of course, because we don't have real lungs. The number one button to learn is, your favorite button would be the alarm. This little bell up here, you can quiet it for 2 minutes. So I'm going to try to remember to keep hitting that each time. I actually have some test lungs here. Not a Tesla, test lungs that I can hook up. That's nice, we'll see. But right now, I want you to see how this screen looks. I've been talking about 2 settings, PRVC and CPAP, which you've all heard of CPAP. Maybe we're CPAP at night. That's when you're getting to where you might be weaning somebody off. But we're going to talk about this PRVC. Now again, I've shut this up for 2 minutes, but I'll try to remember to quiet it. When we have settings on this vent, these are the settings for the vent. This is the settings for the patient. That's what the patient is doing. This breathing 59 a minute, these humps, that's pretty fast, but it's because there's no resistance in that because it's fake. So the doctor will give these settings. When you first turn on this vent, it's a computer screen. It defaults to some typical settings. That's pretty good to go with. You can get orders. Orders are being obtained. The respiratory therapist maybe is hollering at a physician, do you want the PEEP up, the whatever, so they'll adjust it. But we're going to talk about these settings that we set it at and then what the patient does. Oxygen, 60%. That's a pretty normal amount. When we can't set it any more than 100%. When you first intubate somebody, you probably start at 100 and quickly go to 90 or 80. My understanding is these COVID patients are requiring high amounts of oxygen. So they're probably not going to start out at 50, 60%, I assume. You can change these buttons real easily. Whoops. All you have to do is poke it. There's a plus, you go up, maybe 70%, or you go down. I learned this from these videos that are out that we have to watch. But you can do it this way, just a little there. But we're gonna go back to our 60%. Do the little check mark. Yes, that's what I wanted. So there's our 60%. Now you knew room air is 21%. So we're at 60, just to give you an idea, 100's the most. PEEP. I explain PEEP as your lungs are like a bunch of grapes. You know how you might buy grapes at the grocery and there's some squishy wet ones and then there's the nice plump ones. Our lungs with those alveoli and grapes, you want them to stay plumped open, the nice plump grapes. So when you think PEEP, think grapes. We all have a PEEP of 5. That's why the machine defaults to 5. But the COVID patients are taking apparently up to like 20. So it might be 8, 10, 12, can go up to 20, I believe. I doubt they're going to be at 5. So PEEP helps keep your grapes open. Respiratory rate, that's self-explanatory. That's what we set the rate at. I think these folks are set at a little higher rate. You know, the vent is a computer screen that we can adjust, but every patient is different. So this is going to always be a little different, but you get the idea. I'm going to do a little something. I'm going to set up my fake lungs so I don't have to worry about that 2-minute thing. See your little lungs? That thing's gonna race. It would normally be connected up there, you know. You'd be suctioning down your lungs. I don't have to squawk this thing, silence this thing every 2 minutes, I don't think. I think it's kind of catching up. This waveform certainly changed. He's breathing a lot slower, but we've got it set at 15. Maybe this is too distracting. Let's keep talking. Setting up that fake lung, it's called a test lung. We actually get numbers over here so I can talk about them. Let's talk about tidal volume. I compare tidal volume to balloons. It's how much you're filling the balloon. A little tiny person might have 300 of tidal volume, a bigger person 600. I don't even know if we ever set it on 600 anymore. So there's the tidal volume. The lower the tidal volume, probably the smaller the person. The higher the tidal volume, the bigger the person. 500 is pretty normal. Over here is what the patient's doing. So he's breathing 24. We've got it set at 15. Just because you're on the vent, just because you're on this setting, doesn't mean you can't add your own breaths. PRVC is what we use all the time. It's what I'm most used to. I call that's helping the patient the most. It doesn't mean they're in a coma, they're half dead, they can't take their own breath. He's taking breaths, this would be very typical. See this tidal volume? Remember, we're giving him 500. This is what he's pulling in on his own. So he's filling his balloon. I guess I'm saying that all right. That's what he's doing, but we give him 500. But that's what he's contributing. Here's a little capital P and a peak. That's peak pressures. If I stood here and crimped that ET tube, that's going to increase your pressure. If he's got a big mucus plug in there, big wad of snot, it's going to add some pressure. So peak pressures would start going up. This is nice and quiet. 20s is good, even up to 30. But if your lungs are full of whatever, if they're full of terrible pneumonia, if your grapes are getting squishy, if things are not doing well that way and your oxygen saturation on the monitor is all doing poorly, between respiratory and the physician, they'll make these changes, but that's when you might see the PEEP start going up. If I stood here squishing this, that's gonna, I probably could make this alarm. Well, I'm not gonna get into that. That would be some resistance, causing some pressure. And so they might have to make changes. I think that's why we see, I understand, I mean, we're not loaded up there with COVID patients, but that's when you get these, start adjusting these things higher and see different numbers and a lot more squawking, but that's between respiratory and the physician. Let's go back to PEEP. PEEP stands for positive end expiratory pressure. If you just listen to those words, it kind of describes it. The positive end of your expiration, positive pressure. It's keeping those grapes popped open. If it's hard to do that, if that's getting difficult to do, you go up on PEEP. Positive end expiratory pressure. I got rid of our fake lungs. Let's go back to alarms. So if things are alarming, you know what the most common thing is? If the event is alarming, you've turned the patient side to side, or you've done oral care or something, and somebody didn't put this on real well, and it falls off, and the alarm squawks, and people freak out, and they come in, oh, what's going on with my vent? And they're looking here instead of here. All you need to do is find the end of it and pop the thing on. That's usually the number one reason for an alarm. Or maybe they're coughing. So many times we have family say, they get all upset because they're making a gesture that they're coughing. Well, that's okay. You can cough, you're gonna cough. That would cause an alarm though, high pressure, because you're some resistance, force against the vent. You know, if you think about it, these folks are breathing through a straw. And here's what, 6 foot of tubing or something. So that's hard to do. And if you cough, that's going to trigger some alarming, some resistance, peak pressure up, but that would be just for a little bit. If something happens, you need to, if the tube came apart or they're really hard to suction, if you've got any problem going on and you have to use the ambu bag, well, you pop this off. I get that thing off. Get this on and you're bagging them. Now maybe this is falling to the ground and this is squawking and all that, but you can always do this. Remember, you can always do an ambu bag. By now, you're hollering for somebody, you've vocerated somebody, and getting some help. That's the ambu bag. Okay, we've talked about some alarms. Again, I'm just hitting the high spots here. Remember, with all that's going to be coming, I hope all this is for naught. I hope we go through all this business and we don't have to do a thing but thank each other for being willing to step up. But if it should come to this, remember, we may end up with ventilators in the rooms that aren't even looking like this, but they're all going to have settings. They're going to have what we set it at. There's going to be what the patient does. There's going to be physicians and respiratory therapists. We are not alone. I'm not exactly sure how this is going to work. As we all know, it seems to be changing every day, if not more than once a day. But so we're at least getting the gist of it here. Caring for a patient on the vent, it probably needs not sucked out of there somehow. Listening to lungs like any other patient. Oral care. Sedation. These folks are going to be sedated. I have none of it hanging in here, but there's typically 2 things we're going to use. Propofol or Diprivan, which is the white one, the white milk-looking stuff, or fentanyl. When you have propofol hanging for sedation, you know, everything's on a guardrails, which is great for safety. You can see the mics. The most you do on propofol is 50 mics. So if the patient is totally sedated, deeply, the most that's going to be is at 50 mics. When we do our charting, we chart RASS. RASS is Richmond Agitation Sedation Scale. with these folks, we're aiming for pretty sedated, -4, -5. If you think about it, -3 is moderate sedation when you might have a scope or a TEE. That's moderate sedation. So something more than that is really, really out. And so when you do oral care or suctioning, you might not get much response. So that's sedation. Maybe the propofol is only at 10 mics. When we start out on it, we start out at 5 or 10, and you can, like I say, you can go up to 50. It could be, we rarely do Versed. It's typically benzos are bad, but we might be hanging Versed for sedation or giving it as needed. Fentanyl is very typically used for the discomfort of an ET tube for analgesia. Fentanyl might be at 100, 200 mics an hour. The most you go there is 500. There might be other PRN things we're giving, but it would be very normal to be sedated, pain medication. Not normal, it's a given. They're going to be on that. When we get into very sick that they need what you call vasopressors to get their blood pressure up, then that's a whole nother ball of wax. That's like Levophed. That's a whole nother chapter, a whole nother filming episode. Restraints. I don't know who all has worked with restraints, but you can't do enough documentation. There's not enough T's to cross or I's to dot. You cannot chart too much when it comes to a restraint. And the number one thing is getting an order, and you have to do every 2-hour checks, and these folks will probably be restrained because the last thing they need is to pull out that tube. Well, why would they need restrained if they have sedation? Well, they're probably unpredictable. You don't really know what's happening. What if they moved and they didn't even know what they're doing, but their hands get tangled up in the tubing and it comes out by accident? What if propofol doesn't work for them? Anyway, so they're restrained. I'd be shocked if they aren't restrained. That's a whole, yeah. Okay, so I just want to say thank you for watching this. I'm sure you have 99 questions each. You can track down any ICU nurse, a charge nurse, our clinical managers. Track me down. You can track me down on Facebook. I think they're going to keep this Mr. Mannequin in here, I would like to think, for a few more days, and people can do hands-on and mess with it. I know myself and Ashley Stombaugh, a day nurse on intermediate unit, she and I are going to be doing a whole lot more education over the next week. You can hit us up. We're hitting night shift and day shift. OR nurses, track me down. Cath lab nurses, track me down. Or any of us associated with the unit. Ashley's great on intermediate unit and will help answer your questions. And so I'm going to say thank you, and we're done.